introduce myself and everything then. Just tell me when to go.
We're all set.
So hi, Heather Laird-Fick. It's so good to see all of you again. And I'm going to be talking with you about non-alcoholic fatty liver disease, which I'm going to convince you is actually one of the big emerging diseases that's going to have a huge impact on your career over the next 20 years, but hopefully not personally on you. All right. Except now though. So we're going to start with just a patient scenario. So, and this is drawn as a composite of many people you have probably seen yourself in the clinic. So a 47-year-old female presents for follow-up of abnormal liver function test. She had an AST of 75, an ALT of 120, and her alkaline phosphatase was normal. The labs were done as part of a life insurance screening examination, not because of symptoms or anything. Her past medical history is notable just for migraines, gestational diabetes during her second of 2 pregnancies, and after that she had a tubal ligation. She just takes ibuprofen as needed for headaches. She's divorced, sexually active with 1 partner, does not drink alcohol or use tobacco, and denies all use of illicit drugs, including marijuana, and she's currently working as a bus driver. So what are you worried about with her? Somebody comes in with these mildly abnormal LFTs.
Non-alcoholic liver fatty disease.
You are so smart, Nabil. I don't know how you ever came up with that. Yeah, so, and the key is here that you already know that she's completely denied alcohol, so it's steering you down this path. But you also need to remember that there's a differential diagnosis as well. And in the past, sometimes what we've done is patients have one set of abnormal enzymes. You would say, oh, they're not that high. We'll just recheck them again. What do you think about that approach? Why not, Shilpa?
You always have to have a high degree of suspicion when you have abnormal LFTs, whether you're checking for, you know, other diagnosis besides NAFLD, whether you're checking for hepatitis, whether abnormal LFTs are always abnormal. So you always have to.
Yeah. And once they've been abnormal, even if they go back down and they're normal on one test, doesn't mean they're not going to pop right back up. Now, if someone's had shock liver, okay, you know, maybe treat their shock and worry about that later. But in this case, absolutely, it's abnormal. Once it's abnormal, it needs a workup. So this is a disease that we used to kind of poo-poo and not really think about a whole lot, but it's becoming more and more common for reasons that we'll discuss. This is just to show you that back in 2018, there were new guidelines that were put out regarding this for the diagnosis and management of NAFLD. It says that for patients with unsuspected hepatosteatosis detected on imaging with signs or symptoms attributable to liver disease or with abnormal liver chemistries should be evaluated as though they have NAFLD and worked up accordingly. If they have incidental findings on imaging but don't have any symptoms, they should be assessed for metabolic risk factors and alternative causes for hepatosteatosis, such as significant alcohol consumption or medications. So absolutely, you've got to take this seriously. The problem, so this is just to go back and think about some of the pathophysiology. So we know that there are a number of metabolic factors. So dyslipidemia, high fructose or glucose diet, sedentary lifestyle, high levels of free fatty acids derived from fatty tissues, hypercholesterolemia, gut-derived metabolic products, uric acid, et cetera, can all result in fat deposition within the liver. So that can progress, and you start to really encounter problems when not only do you have, the fatty infiltration, but you've also got inflammation that is lobular in nature that can then go ahead and progress to non-alcoholic steatosis hepatitis. So, and this is because of oxidative stress, you get hepatocyte and DNA damage, and at some level, this can become irreversible. Luckily, still, even at the NASH level, if you intervene, you can see that patients can swing back and have regression of their disease. There's a number of different inflammatory cells that have been involved in this. So they've looked at CD8, CD4, cells, macrophages, all of these different kinds of things. And that's important just because at some point those may become therapeutic targets for these particular diseases. Once somebody actually has developed mild fibrosis, they can of course stay at mild fibrosis. Maybe they might be able to regress, but by and large, they're going to go ahead and progress to advanced fibrosis and cirrhosis, and then have that increased risk for hepatocellular carcinoma. So at what age can these things, all of these risk factors, start to come up?
Any?
You know, do you have to be 40 to have these risk factors?
There's no minimum age, but I think the age that I think people start detecting
So
signs of NASH or fatty alcoholic liver disease or early form.
yeah, so to actually get to NASH, I mean, you would expect somebody to be, to probably be at least 30s, potentially more than that. Traditionally, you would have expected that. Problem is now we have kids who are being diagnosed with type 2 diabetes before they're 10. Right? So that's going to be part of what's driving this epidemic, or all of these metabolic factors that are occurring at very, very young ages. I don't know if any of you ever learned this back in pathology days, but you'll start to get the first fatty streaks within the vascular system and the aorta by age 4. Well, that was before obesity was endemic, not just epidemic. It's everywhere, right? And so all of this is really getting accelerated. There's also been increased interest in this idea of intestinal permeability that would then tie back to those gut-derived metabolic products. This used to be something that was seen as really kind of outside the realm of mainstream medicine. Oh, leaky gut syndrome, and people would come in with all of these symptoms and blame it on leaky gut. There's actually more and more interest in looking at this, both from a translational science side of things, but also to see if there are interventions that it could actually repair or decrease that uptake of gut-derived metabolic processes to help intervene both for NAFLD and potentially for some other diseases. But remember, even though this is really worrisome, and if you have a large number of people who are entering here, if it's 1 billion people, even if it's a 1% who make it to HCC, that's a hell of a lot of people, right? Versus if this was very, very rare, we wouldn't even be talking about it. What we do know though, is that for better or worse, people with these metabolic problems are actually more likely to die of cardiovascular comorbidities by and large right now. That's changing. The mortality rates for cardiovascular disease are going down, probably because of statins and some other things. So at some point, we may actually see these start to break even, at least, as we see more and more liver problems. So really something to think about and worry about into the future. So you're worried. This is a woman who you need to know some more information. So what were if we just go back to her case, what were the things that are really big warning signals from us just from this information that we've got?
Gestational diabetes, maybe?
Yep. So just because of that, she's already got a 50% lifetime risk of developing type 2 diabetes, right? So very, very high risk. And then luckily she doesn't use substances that we would worry about affecting the liver. But the fact that she's a bus driver is also a little bit concerning for that sedentary lifestyle. So something to think about as well.
Dr. Ladvik, what about the NSAIDs use? Like she takes ibuprofen, will that?
Yeah, so I think as long as she's using it intermittently just for her headaches, nah, not really a big risk factor for the significant liver injury or making anything with a potential NAFLD worse.
So we see a lot of patients who are obese and have all these comorbidities, but not all of them develop the degree of liver cirrhosis and fibrosis. So what make these people at high risk of developing this situation? Is there something genetic behind this that makes?
Hold that thought. We're getting there. So, and some of what we don't really know, there are some risk factors that we know, and that's going to be coming up. right now, while you've got this patient in front of you, you do need to be thinking not just about, does she have NAFLD? You need to be thinking about, does she actually have more advanced liver disease, or does she have a different cause? So what are some of the things that you want to know on history about her?
Ethnicity and family history.
Okay. So no family history of liver disease, but lots of family history of diabetes. I have to make sure I remember my slides correctly. And she is very, very Caucasian and has lived in mid-Michigan her whole life.
Probably
I would like to know more about the diet, her diet. What's her lifestyle?
Yeah, so fairly sedentary, typical American diet, which usually means too much calories, too much sugar, too much fat. What else?
Cardiac risk factors.
Like,
BMI.
so her BMI you'll get on the physical exam. So history, what are things that would make you think that she has chronic liver disease already?
Vaccination for like hepatitis, I guess is something else I'd be curious about.
Well, if she has a history of hepatitis, Maham, or what?
Vaccinations, if she's receiving
Vaccinations.
vaccinations.
Okay. Yep. She's old enough. She probably never received vaccinations for Hep A or Hep B.
Easy bruising, abdominal stria. It's kind of like physical exam finding.
Yeah. So thinking about, anything that might make you worried about ascites, increasing abdominal girth, those kinds of things. What other kinds of symptoms or can you get related to chronic liver disease?
whether she's had any hematemesis ever, melena, stigmata of GI bleeding.
Yep. So that would be way down on the cirrhosis end of things. What else?
Is her liver enlarged on physical exam?
We're not to physical yet. We're still on history.
Okay.
Yes, we would look for that. Yep.
And he's like spider angiomas, telangiectasias, gynecomastia in males.
Palmar erythema.
Yeah.
Yep. So you're telling me a lot of physical exam things, which you could also ask her, but you're probably going to check for them too. What's a symptom she might complain of?
Pruritus, like itching.
Anorexia.
Itching. Yeah, absolutely. Maybe a
Right
big
upper
issue.
quadrant pain.
Pain. Yep. Absolutely.
Lower lymphedema.
Yep.
Menses irregularities.
Mm-hmm. Yep. Might have easy bruising, bleeding. I think somebody already said that one. In addition, lower extremity edema, some of that kind of stuff. The gynecomastia, hard to assess in a woman, to be honest.
Shortness of breath as well, perhaps, if she develops
Maybe.
some pleural effusion sequelae.
Yellowish
Yeah.
discoloration.
Yeah, so any icterus or anything like that. Yep, and a lot of these are really truly the cirrhotic end of things. The itching is actually one of the earlier symptoms, and right upper quadrant pain can be associated with just the hepatitis stage as well, the steatohepatitis. So physical exam, I think you've pretty much hit on. You'd also, if there were other metabolic risk factors and things, for alternative causes of either steatosis, which we actually haven't confirmed, or just liver disease, what are other things that you would think about?
Well, I think in kind of her age, of early 40s, and no, you really can't rule out autoimmune.
Autoimmune hepatitis, absolutely.
Alcoholic.
What's that, Emma?
Alcoholic liver disease.
Yep, and she already told us she didn't drink alcohol. Doesn't mean you have to believe her, and it doesn't mean that she didn't used to drink alcohol, but she told you no.
Hepatitis C.
Hepatitis C, yep.
Hemochromatosis.
Oh, what was that?
Hemochromatosis.
Hemochromatosis, absolutely. Yep.
Wilson's disease.
Yep, and she's definitely on the old side for Wilson's disease, but if she was even in her 20s, that should definitely be higher up on your differential.
This is probably low.
Alpha-1 antitrypsin, ANA,
But
and
on,
anti-muscle.
Well, yep, so we're going to get to the testing things first as we go through.
Oh, okay. I thought we were doing that.
Yeah. Yep, sorry, yep.
Yeah, primary biliary cirrhosis and primary, the primary biliary cirrhosis.
Yeah, and the thing that makes that less likely is that her alkaline phosphatase was normal on her initial testing. So you're worried more about a hepatocellular thing, but doesn't mean that you shouldn't have that in the back of your mind. absolutely.
This is kind of lower on the list, but non-hepatitis viral etiologies like EBV hepatitis and stuff like that.
Yeah, and those tend to present more acutely with hepatitis rather than with chronic liver disease. So, but absolutely, she could have that and have been otherwise minimally symptomatic related to that. And Mark, I should have told you this. This is all related to things that are going to come up and that teaching you're doing with medical students soon. So,
Yeah, I saw
gotcha.
yeah.
Excellent. Okay. So, oh, my advancing thing doesn't work. So you're going to ask all those ROSs. You're going to ask about immunizations, risk factors for viral hepatitis, other than injection drug use. What other kind of risk factors would you worry about?
Sexual history. I think that was in the first slide though.
Yeah, and actually viral hepatitis is less likely to be transmitted sexually, at least for hep C, not so much hep B maybe, unless you have multiple partners potentially seen within sex workers, but usually not in monogamous relationships.
Blood transfusion before a certain
Oh, my hearing sucks. What was that?
Blood transfusions before a
Yeah.
certain
Yeah, absolutely. And especially blood transfusions outside of the US. So for her, the screening process has gotten so much better that unless she'd had childhood transfusions, she shouldn't necessarily be at risk, but something to think about.
IV drug use.
What was that?
IV drug use.
Yeah, absolutely. Would be a big one. And potentially for HIV, at least, we even worry about snorting, because if you're sharing implements, the risk of actually having small arterial bleeds and things from the nose and having exposures that way might be an issue as well. Soda intake is actually considered a metabolic risk factor for this as well. There have been some studies that looked at that. Mexican Americans in the US are at much higher risk, probably because of the underlying metabolic risk factors. Just like we know that some Native Americans, American Indians, are at very high risk for type 2 diabetes. So you might worry about this in them as well. Family history, metabolic diseases run in families. And it'd be helpful to know if there had been prior labs or prior imaging. Just like in pulmonary, an old chest x-ray is worth its weight in gold. So it might be if there had been old imaging of the abdomen that maybe they hadn't even really focused on the liver, but there still may be some cuts that would be useful. And then again, as you said, on physical exam, you're going to be looking for the stigmata, the chronic liver disease, and also potentially for stigmata of other causes of liver abnormalities. So for example, autoimmune hepatitis can be associated with some Cushingoid features. I have no idea why. If you can figure out why, let me know. With hemochromatosis, you might get kind of that bronzy complexion. If you were worried about Wilson's, Kaiser-Fleischer rings, and those kinds of things might come up as well. So the question is, how well do non-invasive tests help us diagnose? So there's a whole bunch of things that you can think about. Things like the glucose and lipid panel are really going to be just looking for those metabolic risk factors that would make you think more about NAFLD versus the albumin, prothrombin time are really helping you think more about the severity of the underlying liver disease and if there's already some advanced fibrosis. The ferritin would be, again, to rule out more the hemochromatosis, ANA and anti-smooth muscle antibodies for the acute or the autoimmune hepatitis. And then there's these other ones, the CK18, adiponectin, and resistin, that are still pretty investigational to see if they're actually helpful in confirming the diagnosis. AST and ALT levels or ratio, I mean, the ratio we think about whether it's likely to be alcoholic or not, but that's about it. And then the imaging, you can actually see the steatosis on any of these. Ultrasound is often the first level that we get because it's cheap, inexpensive, no radiation, all of those kinds of things. Now, and this is just to emphasize that unfortunately, most of the non-invasive tests have very low sensitivity and specificity, and that the scoring systems that exist, I don't know if you can see this because your pictures are over it. There are some different scoring systems that are available, but their pooled sensitivity and specificity are not amazing, and they really need to be validated prospectively as well. So again, another potential area of research and interest for folks who are going into GI or maybe even metabolic, endocrine metabolic disease work. So I'm gonna move this again. So thinking about when you would actually get all of the different types of imaging studies, again, the nice thing about the ultrasound is that it's cheap and easy to do. If you have very low levels of steatosis, or if you have very high BMI, it sucks. You could very easily miss it. Having said that, in most people, it's still going to be first line. CT is good if you have moderate to severe steatosis, but not if you've got the more mild changes and there's the radiation exposure. So it's not really recommended by and large, but a lot of people have CTs for other reasons. Oh my goodness, why can't I? Oh, the ultrasound with attenuation by fibroscan. You can also look at, they're still trying to figure out how best to use this because it just hasn't been very well standardized. And then the MR-based techniques, there are some special things that MRI, PDFF, for example, you don't have to worry about body habitus that's doing this. You're able to look at the entire liver, but it's very expensive, time consuming, and operator dependent. And of course, you can't use it in people who have implantable devices. So at this point, it's probably more limited for people who are in specific research protocols or have inconclusive other studies. Here are some of the biomarker panels. And again, just really not sure how useful these are. The fibrosis 4 index you may have heard about, and it may help to decide if somebody's at very low risk or high risk for advanced fibrosis or cirrhosis, but it's not going to help you with the vast majority of people, or with a number of people who are somewhere in the middle, and you would have to go to a more sensitive and specific test. Here, so you can see all those, and I'll send Abdullah my slides. So there is the NAFLD fibrosis score that can be helpful. It's been looked at in some different cohorts with about 5,000 patients. There was some statistical heterogeneity that you can see here, meaning that although there was an association with increased mortality, relative risk of 4.54, that statistical heterogeneity suggests that there's differences between the cohorts and things. So it's really hard to know for sure, but it's non-invasive. It's something easy to do, so you can consider using it rather than jumping right to liver biopsy for prediction of mortality outcome. Have you guys ever done the NAFLD score? Here, we'll jump to it. And you'll have to tell me, I don't know if you can actually see it now. Let me just share my screen. So when I jump to my browser, apparently nothing happened. Here we go. You can see, I can't remember how old she was. Let's say she was 44.
47, I think.
She was 47?
Mm-hmm.
Okay. Her BMI, we'll make it up. We'll do 32. She does not currently have diabetes. This was what, 75 and 140 or something? Or
170 or something.
Yep. We'll give her fairly normal platelets. And what do you want her albumin to be?
2.
Ooh, okay. Yeah, she will definitely have liver disease if we give her 2, because that's really bad. So if it's, oh, no, it still wasn't bad. So greater than 0.675 suggests significant fibrosis. So she's in this indeterminate score range. And that's only because she had such a low albumin. If we went ahead and gave her a more normal albumin, I don't know if it'll reset for me, but it should bring her score up. Anyway, trust me, it would.
Quick question. So I saw obviously ultrasound, CT, all those good imagings. Where does elasticity ultrasound fit into that in terms of
Yeah,
using
so
that?
that's the FibroScan one that I mentioned.
Hi.
Oh, or maybe I hadn't gotten to this one yet. But it does talk about the CAP is an ultrasound with attenuation by FibroScan. So looking at the elastography, and I think that may be coming up on the next step. Yeah, here, the VCTE to measure the shear wave, which is related to liver stiffness, which is the FibroScan. So, and again, it helps if you're at very low risk or at very high risk, but it doesn't help you if you're in that intermediate range. And that's where you're kind of stuck and where you might actually consider doing a liver biopsy if there was uncertainty and the patient wanted to go that way versus, because even the MRE, you're looking at only being able to really identify patients with advanced fibrosis. So it means a lot of patients, you're not going to be sure how to categorize them, which is a little bit frustrating.
Hey, that's what I thought. It's almost impossible to tell between just like an NAFLD and NASH just from imaging and from like because you use the inflammation from the biopsy to tell if someone has NASH. I guess that's what I was always taught.
Yeah, absolutely. And you would also expect somebody with NASH might be more symptomatic, but it's not a definite thing. But I recently had a woman who was from an indigenous patient population in Central America who came in with some inflammatory symptoms, pain, abnormal LFTs and everything. And so, and her fibrosis score was fairly low, but they went ahead and did a biopsy just to get, and that's still pending, just to confirm whether or not this was actually NASH that we were dealing with. So this is just from a World Journal of Gastroenterology. So if you exclude other things, if you still suspect NAFLD, you assess with an NFS or a FIB4 index, knowing that it's not going to help you with everybody. So if it's very low, you can consider rechecking it every 2 years and you emphasize the need for lifestyle interventions. If it's very high, then you don't necessarily have to get the biopsy. You just need to manage them and their risk factors and think about screening for liver cancer. If they're in that indeterminate risk, think about reassessing the elastography and consider a liver biopsy to confirm one way or the other. Okay. So a picture to demonstrate what we just said, a flow chart. Okay. Trying to figure out where to put you guys' picture so I can still see. So she wants to know how serious this is. So she comes in, her albumin is pretty normal. She has normal renal function. She does have elevated fasting blood glucose twice. So she has popped up into having diabetes. Platelets are pretty normal. Her triglycerides are too high, moderately elevated LDL, PT is normal, and she has fatty liver on her ultrasound. So if we put these scores into that NAFLD, she's going to fall into probably that low risk group if we went through and did it again, but she might be intermediate. So is this going to be a problem for her immediately? No, but what does she need to do?
Have adequate follow-up.
Lifestyle modifications too.
Control all
Yeah.
comorbidities.
Yeah, she needs to change her lifestyle and she needs to make sure that she follows up with a doctor because she's got ongoing risk. And she's a pretty young woman. I mean, she's probably going to live another 40 years. So, okay. So there are some things if you, sorry, can you guys see your own pictures or am I just annoying myself by moving you around?
We can see our own pictures.
Okay, excellent, great. Well, I moved you to the bottom. If you think that up to a quarter of the population has non-alcoholic fatty liver disease, which is a very, very depressing thought. Again, you can have people who have borderline changes, can go on to have NASH, Of the people who actually develop NASH, up to 42% of them can start to develop fibrosis. Some of these with very early fibrosis might be able to get a little bit of improvement or stabilization, but there's certainly people who will go on to develop cirrhosis. And once you've got cirrhosis, your annual incidence of hepatocellular carcinoma is somewhere between 2 and 13. So the key is that if you can start to change these risks, thinking about the sedentary lifestyle and high caloric intake, obesity in and of itself, if there's underlying insulin resistance, there's interest in some genetic modifiers that might be helpful. Pretty sure we can't modify people's age, rats, but certainly as they get older, their risk for continuing to move forward towards cirrhosis is much higher. And that can also vary by gender.
Dr. Lertwick, is central obesity more of a risk factor than generalized obesity, or is that?
I don't think it matters for this one. And I don't know if they've actually gone down and figured that out. I think they just used BMI when they were defining this in the studies, but that's a great question. So here you can see, this was a cohort that they followed. I believe this was out of like Northern Europe, Scandinavian countries, but they found that it was really that your risk of progressing to cirrhosis or chronic liver disease at F0 and F1, very, very small. But by the time you even got to the second stage of fibrosis, you had 5.48 relative risk of that occurring within the next 20 years. If you were up to fibrosis 3, you were looking at progression within the next 6 years. So this is already pretty significant. The problem is how many people see the same doctor for 20 years? I've got a few in my practice, but that's getting pretty rare these days, right? So that's why not just having good follow-up, but also having good health literacy and awareness of this could be really important as well.
Dr. Lertwick, I have a question.
Yeah.
If a patient does not meet the criteria based on the ACC or to start a statin for whatever, if they're not diabetic, but they do have fatty liver and their LDL is not too high, but like this patient, her triglyceride is in the 400s. Right. Would you start a statin or just do like lifestyle modifications and follow up?
That's a great question. So, and we'll get to the therapy. It's not clear that starting her on a statin would actually prevent her from developing or progressing with NAFLD, but her triglycerides are high enough that you start to worry about pancreatitis. So you're going to treat her lipids and her triglycerides no matter what. Okay. Yep. And that could include, if she can drop them down some, it might be just lifestyle, but I'd like to get her closer down to the 200s at least, fairly rapidly. Okay. So this is just
250, right? The cutoff is 250 for triglycerides?
For treatment? Yeah, and it's changed over time. I think that also depends if you're looking at the cardiovascular recommendations versus other metabolic recommendations. But yeah, I usually don't get real worried if people are in the low 200s. So we also know that mortality goes up significantly, and here it's not. You can see that the relative risks aren't as high as it was for the progression, but still with stage 4 fibrosis, you've already got a 5-fold higher risk of death. So that's nothing to sneeze at. And right now they're actually concerned that NAFLD is going to become the #1 cause of liver transplants internationally because of the obesity epidemic and how common this may become. Not because everybody progresses, but because it's such a huge baseline population at risk. And here's just overall mortality. So this would also include death from non-liver related causes. So as I mentioned, there is a different risk related to sex. And so if this was a study that was looking at women, and overall women had a lower risk of NAFLD compared to men, but had a higher risk of actually developing advanced fibrosis, particularly in the studies that had average ages of 50 or higher. So that makes sense, right? The older you are, the more likely you are to have had fibrosis. And in this, so it may be that there are some protective factors for women earlier in life, and then as the metabolic factors are building over time that it elevates the risk. We're not really sure, but something to really, really consider in your older female patients who have metabolic risk factors.
Kind of the same idea with coronary heart disease. After 50, they have less estrogen, they have
Well, yeah, and with that, we think it's the estrogen that's protective. I don't know if we think that estrogen is protective from the fatty liver disease or not. Maybe. Estrogen has its own effects on the liver, aren't always salutary, but that would certainly be a hypothesis. Yep. So I think Shook got to a really important question. Great. So I've identified somebody who's at risk, who maybe already has NASH. How can I treat it? And the question would be, if you were looking and trying to do a study and you wanted the gold standard study, what would you be looking at as a treatment outcome?
decreased rate of progression to fibrosis.
So you could look at rate of progression to fibrosis or regression of steatohepatitis, of NASH would be one thing. What was that, Abdullah?
Mortality benefit.
Mortality benefit. Yep. I mean, that would be the gold standard, right? Problem is, you're going to have to follow people for more than 30 years. So that's not very helpful. So often we're stuck with these biochemical studies is the point that I wanted to make. And even looking at progression to fibrosis, you probably need a fairly long study, right? Based on the timing that we were looking at of whether or not they were going to progress or not. So most of the studies are powered to look to see if NASH regresses, which isn't enough to say that, well, which is reassuring that they regress. Doesn't mean that they won't progress again. But anyway, just something to think about as you're going through these studies. So they have looked at just trying to address insulin resistance. So we'll talk about some of those things. You want to prevent the second hits. So going back, you know, there was that whole long list of things that could result in oxidative damage and all of those kinds of things. So you want to try to address as many of those factors as possible, because it's probably not just a one-hit disease, it's probably all of these things coming together. Most importantly, we know that you want to prevent complications from the other more comorbidities, such as the heart disease. And finally, secondary prevention for liver disease. So the second hits could include something completely outside of that pathway and be more about Hep C and addressing factors for that, or immunizing for Hep A and Hep B, et cetera, kind of the standard things that we do for people who have other types of liver disease. So the biggest thing that would be really cost effective if we could make it work, right, is just to have people do lifestyle. If this is a metabolic problem and it's related to insulin resistance, focus on exercise or diet, right, to try and make this happen. And so they looked at the exercise of moderate to high volume, moderate intensity, improved both the labs, although again, we said that's somewhat limited, but also evidence for steatosis. And they found that diet plus exercise improved labs, but they didn't show an improvement in steatosis. So here the exercise is actually more important, which is the harder thing to do potentially. They also looked here in this study, and they said that, you know, all you might have to do is get people to lose 5 to 10% of their body weight, right? So, you know, those are ranges that we talk about even for improvement of sleep apnea. So it's not huge amounts, but it can still be pretty difficult. So something to think about. In this study, they were looking at 30 to 60 minutes of exercise, 3 to 5 days per week as the recommended amount, targeting, you know, if you've got somebody who weighs 200 pounds, you're trying to get them to lose 10 to 20 pounds. So not easy, but doable, quite achievable. They've looked at a number of different medications to see if this could actually make a difference. So thiolidazine diones improved the inflammation, but not fibrosis. Not surprising. You know, we already talked about if you get past that F1 level of fibrosis, it's pretty much considered to be non-reversible. Metformin should have been fantastic, right? Unfortunately, in the studies that have happened, they actually saw a worsening of inflammation. So our go-to drug for diabetes is not necessarily the answer for NAFLD. There have also been some studies looking at vitamin E, and that showed improvement in inflammation, but not in fibrosis. And it's only been studied in patients without diabetes and should not be recommended in men because of the link between vitamin E and prostate cancer in some prior studies. So,
Sorry to interrupt. Just a quick question. Has there been any studies done in terms of like Ozempic? Because I know Ozempic causes weight loss as well and things like that.
Hold on for another slide. It's coming.
Sure.
Yeah.
Hey, Dr. Layerford. Sorry, I have another question. So if we do see evidence of fatty liver, should we discontinue metformin for these patients?
So not, if it's just that they've got fatty liver, not necessarily, but you might be more aggressive in evaluating them for NASH, because that's where the concern is, that if they'd had NASH and they were put on metformin, the inflammation actually worsened. So you would work really closely with GI in that case.
Okay. Thank you.
Yeah. So there's several systematic reviews looking at the newer anti-diabetic drugs for this. So there have been, in this particular one, they had 7 different studies on liraglutide and exenatide. And they were looking at evidence for just fatty infiltration of the liver based usually on ultrasound, or I believe in some cases on CT. And then they were also in some cases looking for biopsy steatohepatitis as well. The problems were that even though they had some positive studies here, we've already talked about the limitations of some of the imaging for trying to define how much fatty infiltration there is. And they used slightly different methodologies for that. These were also very small and generally very short trials. So not really enough evidence at this point to suggest those. Sitagliptin has also had a number of different studies that looked either at the changes in the fatty infiltration, the histology, or both. Most of the studies were underpowered. They were 20 patients or less and had mixed results. And so I don't think we can draw any conclusions at all about sitagliptin or the other DPP-4 inhibitors. For the SGLT2 inhibitors, several of those have actually been studied, but again, there was a lot of limitation in the study designs. They weren't necessarily randomized controlled. Many of them were actually open label or had no control at all. And the number of patients was generally fairly small. Furthermore, just looking at this, they had conclusions that you might think about the GLP-1s or the GL2 inhibitors. But the problem is that they didn't even do a very good systematic review. They didn't do some of those analyses to look for statistical heterogeneity, to see if there is publication bias or any of that. So I would really, really view all of these agents with some skepticism and think about that. It might make more sense for folks, if they're thinking about this, to look at clinical trials or things, or maybe you would go ahead and use it just because you're trying to get them to lose weight and improve their glucose control, and you're not focused on the NAFLD. Other meds, they've looked at statins and fenofibrates that have no clear role necessarily. Orlistat, which affects gut absorption of fats, didn't make any difference. Another one that I can't pronounce, and I can't remember what exactly it targets, but it had no benefit. They've even looked at losartan, ursodeoxycholic acid, and lubiprostone, which is one of the agents for treating chronic constipation that they thought might affect the intestinal permeability, and that had very unclear results, probably because it was just a really early trial. But so there's lots of things, and again, they're starting to look at other mechanisms about how they might start to target the changes that can lead on to fibrosis and advanced disease. This was an interesting one that I included that I think is still just in pre-approval range, but they're looking at pegylated fibroblast growth factor analogs to see if that actually makes a difference as well. And they did see a significant decrease in the absolute hepatic fat fraction, but they didn't, and there were adverse events, but again, you don't necessarily have some of that longer term follow-up. This is just a 16-week treatment study. Almost more of a safety as much of as an efficacy study. So patients will come to you and they said, okay, so I know that I have changes in my LFTs. I know that I am developing diabetes, but I still can't lose weight no matter what I do. Should I just get a gastric sleeve?
Doesn't it depend on the BMI and if they qualify for surgery, for bariatric surgery? And the other thing would be medications, like FDA approved medication for weight loss.
So you could talk about the medications for weight loss and things. For gastric sleeve specifically, not for some of the other bariatric surgeries, they've actually loosened up the criteria. I think if you've also got diabetes, you just have to be at a BMI of 30 or higher with most insurances, which is obese, but it's stage 1 obesity, right? So you don't have to be that big. Bariatric surgery, absolutely, for the treatment of obesity and diabetes, is becoming more and more mainstream as they've got longitudinal data looking at the effectiveness of not just treating, but curing diabetes, ameliorating hypertension, sleep apnea, and all of those different things.
Concomitant diabetes with NAFLD, or even just NAFLD and diabetes alone would qualify?
So that is the question. We don't know for sure what it does to NAFLD. And one of the concerns, so there have been some observational studies that have actually shown some improved histology in patients who had NASH, but there are no big studies. And there are some concerns that if you do this surgery, and if this gut leakage or other gut factors can actually affect the severity or presence of NASH, that you might make it worse. So if they've got something else going on, like the diabetes, it's probably safe to go ahead and pursue bariatric surgery, but you wouldn't use it as a treatment for NAFLD or NASH only.
Thank you.
If that makes sense. Okay. So we've been talking about people who are obese. The problem is that there are actually a lot of people with NAFLD who are either lean, so a very low BMI, or in the non-obese ranges. So in this particular study, they were suggesting 10 to 16% of patients who are lean or non-obese. And there's a whole bunch of other studies who look at this in slightly different ways. So you can still be thin, and still have NAFLD. Does exercise still help? We don't know. Do the medications work the same way? We don't know. So I think this may actually end up being a growing area of research and investigation, as well as we realize that some of these folks may still be at risk. The other thing that I'm not sure of, does race ethnicity matter? One of the studies that I looked at actually looked at both Eastern and Western populations, because the definitions for obesity or BMIs and waist circumference that put you at higher risk for metabolic diseases is very different in Asian populations. So that might play into it, but it's still really a big concern, that because if you're lean, you do not have an increased waist circumference, right? Let alone the high BMI by definition. So this is really concerning as well.
May I ask a quick question?
Yes.
So by definition, this diagnosis is made based on biopsy, right? So these patients who are non-obese, do they also have high lipids?
So that's the part so they were just looking at the overall prevalence of the NAFLD. So I'm assuming that was based upon abnormal LFTs and evidence of steatosis.
Yeah, but
imaging. So it's not necessarily NASH or anything. To my knowledge, these studies didn't necessarily go and have all the information about the risk factors, all the metabolic risk factors for individual patients.
Okay, but because hyperlipidemia is the biggest